Could you imagine being a breast cancer patient and finally awaiting your mastectomy only to wake up and find out now your provider is out of network? Now AI is going after senior care. The companies that are using these AI models will get paid based on their ability to deny these procedures. During his confirmation hearings, he said something that sent off alarms like a 5 alarm fire. It's been said that the Big Beautiful Bill is a win for rural communities, but is it? Let me explain. And I later found out that people who had just graduated and who I was supervising were paid more than I was paid. The judge awarded a family nearly $1 billion. Here we go, United Healthcare, once again, because I want you to know exactly why we need to be paying very close attention to the dismantling of the CDC for a reason that most people are not discussing. What you don't know will hurt you. Yes, the CDC has scaled back this food safety program. Is about to be a situation, and God help us. And I don't say that lightly. Which health plan is at risk for being dropped by doctors? Which major hospital is now out of network? Is the field of anesthesiology in trouble, and will our surgeries be delayed? Who just got a big payout for a medical malpractice case? Should we all be praying over our meals? Which program is being piloted for Medicare, but maybe a transfer of wealth? This is your Cliff Notes when it comes to recent health policy changes. Top things you need to know. I'm not just simply relaying health updates. I am connecting the dots. Don't miss also my tips on how to protect your health. You can go topic by topic. This is not just for you, this is for everyone. So definitely please share. And once again, we thank you guys for always joining and supporting. Don't forget to do what? Click subscribe. Hey, you guys, welcome back. Welcome back. Welcome to all our new viewers. Thank you guys for joining us another day. Listen, we have a lot to get into today. Also, before we get into everything, just a friendly reminder, please hit the like button, hit subscribe if you haven't subscribed to our channel, because we do a lot of hard work to bring this information to you. And also so that you know that we have been able to enact certain other features. So you can do a super thanks, you can do donate in just various ways. So take a look at our account and you'll be able to see ways that you can support us so we can continue to bring you the facts and pay some of these bills, y'all, because we're trying to get to the next level to make sure that people have good information, solid information, fact-checked information out there. Preparing for today just really confirmed things that I believed, even things that I've been experiencing. So I've realized that even though my site got included in an NIH study that was supposed to be an incredible study, that nothing has moved forward. And today's session, we're going to talk about a few things that would explain why that happened. I mean, some things you're going to already know, but I'm going to dive a lot deeper into a lot of the news that you've been hearing over the past couple of weeks so that we can kind of consolidate the information and make everything make sense rather than getting the information in piecemeal. So hopefully today will help you to bring everything together. So let's get into it. Listen, I chose my owl today because I want you to keep your eyes open and your ears open. I want you to listen and judge, because I want you to be able to listen to the information, connect all the dots, because let me tell you, all the dots do connect. So let's get into the first thing that's probably the most important thing to discuss today. And it's the most important because it's the most important population for us to pay attention to, the kids. There was an announcement that the Pediatric Brain Tumor Consortium will not be funded moving forward. Yes, this is a network that's been dedicated to early phase trials of treatments of children with brain cancers. And it's been said that this fund will be phased out after 25 years. The National Cancer Institute has backed the Pediatric Brain Tumor Consortium. This consortium was founded in 1999. And it brings together 15 academic centers and children's hospital in the United States and in Canada to run phase 1 and phase 2 trials. It's led studies that have helped with many therapies, treatment delivery technology, radiation treatment strategies that has worked with Children's Oncology Group to move programs forward into larger trials. So this is definitely a key organization when it comes to research on brain tumors in children. And this is why brain tumors is important in kids.
The American Cancer Society. Brain and spinal cord tumors are the second most common cancers in children after leukemia. They account for about 1 out of 4 childhood cancers. About 3 out of 4 children with brain tumors survive at least 5 years after being diagnosed. The Pediatric Brain Tumor Consortium, which has conducted dozens of trials since it was established in 1999 by the National Cancer Institute, has 6 active trials, 5 of which that are related to treatment. These are early phase trials that evaluate the safety and the efficacy of novel therapies for pediatric brain cancers, mostly the very highest risk types of these cancers.
Yes. So as we shared, brain cancer in kids is one of the top leading causes of cancer. And so it's very important that we have this ongoing research. But unfortunately, the Pediatric Brain Tumor Consortium will not be able to apply for another 5-year award to continue their funding beyond March of 2026. This is likely all part of the current administration's plan on cutting $18 billion from the NIH budget for the 2026 fiscal year, understanding that the NIH is the primary leader in research in the United States, and by that, also one of the leading institutions in the entire world when it comes to medical research. So these types of cuts are really important for us to pay attention to. And unfortunately, we're starting to see some of the effects of these cuts real time.
Children's Hospital Los Angeles just laid off 437 employees. That includes bedside staff, therapists, case managers, and other non clinical roles across almost every department. The layoffs go into effect October 28th.
And this is where our study comes in. So we were one of the sites working with CHLA, which is the Children's Hospital of Los Angeles, to work on an incredible study with regards to child development. And this study has not moved forward, at least not at our site. So I do think that we are already starting to reap some of the consequences of these cuts. So it was announced that CHLA, which again is one of the leading institutions when it comes to children's research, and also just the care of the sickest of kids. They unfortunately have laid off a significant number of employees and eliminated 439 positions. This impacts about 5.8% of their workforce. So, according to CHLA's Chief Executive Officer, Paul Viviano, he cited that these cuts as a result of growing financial challenges and an effort to restructure, that the layoffs are part of the hospital's wider goal of restructuring their efforts, right? But this comes after a hiring freeze and already reduction in purchasing costs for supplies. Speculations are that this has to do with NIH funding and the large-scale Medicaid cuts, because CHLA does take care of some of our more underprivileged, sicker kids. It's also been known to be one of the greatest recipients when it comes to NIH funding. CHLA is a major recipient of NIH funding, consistently ranking among the top children's hospitals in the US. For NIH funding to support research in pediatric diseases like cancer, as we just talked about, brain disorders, obesity, and diabetes. For example, in the fiscal year of 2024, CHLA secured $51.4 million in NIH funding, and their research efforts were strengthened by partnerships with USC. Now, one of the most interesting partnership with USC, which again is an academic center, in Los Angeles, for example, is that it really opened the opportunity for more studies to be done, especially on underserved population, which is under-researched. For example, a $24.5 million NIH grant was established for the center with USC to address obesity and related chronic diseases in Latino children and families. So definitely CHLA has proven to be a very critical arm when it comes to research in Los Angeles, but also even on a larger scope, research when it comes to our sickest kids nationally. This leads to another hospital that is having some struggles. Let's talk about Johns Hopkins. So some of you may not be aware, Johns Hopkins and United Healthcare have been in a contract dispute, and these negotiations have been going on for 8 months and had a deadline of August 25th. When guess what? August 25th came and there was no settlement or agreement, causing Johns Hopkins hospitals and facilities to now be considered out of network when it comes to United Healthcare patients. Listen, this is a huge deal. This dispute now leaves thousands of patients on United Healthcare plans unable to receive care at Johns Hopkins. And for many of you may know, Johns Hopkins is a major academic center, one of the leading institutions in the entire world. So the sickest of the sick go to Johns Hopkins in that particular area. And unfortunately, now a lot of these patients are now considered to be out of network. And this is going to lead to potential delays in treatments and denials of treatments. The failure to reach a new agreement has forced all these patients, which is estimated to be upwards of 60,000 patients, literally woke up one morning and found out that their care is now out of network, with one exception, the Johns Hopkins All Children's Hospital in Florida. Now, what does this mean? Unfortunately, this means higher fees. If patients continue to seek care through Johns Hopkins on their United Healthcare plans, they are likely going to face much more expensive care, and it's going to hit them in the pocket real hard. As many of you may be aware, whenever you seek care out of network, it costs you. And so this is just an unfortunate outcome for these patients, but there is one caveat. For those who are in certain categories who are considered to be the most vulnerable when it comes to medical care, meaning that they are sick and need this particular care, and maybe this care, Johns Hopkins is the only one in their area that can provide the higher level of care, they can apply for what's considered a continuity of care approval. So if you are one of those patients and you are under United Healthcare and you need to be seen by your clinicians at Johns Hopkins, you can request for your clinician to provide or to submit a continuity of care form. Now, on their website, you will find a link that leads to a letter that your provider can fill out and submit. And the categories that they will consider, certainly anyone can apply, but especially those who are transplant patients, who are otherwise abled patients, those with terminal illnesses, those who are currently inpatient and confined. Could you imagine being inpatient, meaning you're acutely sick, and then finding out you're out of network? Oh my gosh, I cannot even imagine. Certainly newborns, those who are facing life-threatening conditions, those who have acute conditions, and those who have upcoming surgeries. Could you imagine being a breast cancer patient and finally awaiting your mastectomy, only to wake up and find out now your provider is out of network? That is devastating. So hopefully they can figure this out. United Healthcare, Johns Hopkins, y'all get it together. Make sure these patients are taken care of. And speaking of breast cancer patients and United Healthcare, listen, United Healthcare, y'all have been in the news way too much. You may want to figure out a lot of these situations because we're listening and we're paying attention. And guess what? For most of us, we do have options when it comes to which insurance company we are going to select to be our payment method for our medical care. So, did you guys hear about the case with Dr. Potter and United Healthcare. Listen, I'm going to have to take a sip before we get into this one.
UnitedHealthcare hired Clairlock. They've been hired by the Sacklers of opioid fame, Russian oligarchs to threaten journalists, and they threatened you. How does it feel to be in their crosshairs?
My grandfather always told me that if you weren't pissing someone off, you weren't doing it right.
Dr. Elizabeth Potter made national news for doing what many doctors wouldn't, publicly calling out health insurance companies.
Insurance just keeps getting worse.
Dr. Elizabeth Potter, who's performing cancer surgery, scrubs out when she gets a call from UnitedHealth.
And the gentleman said he needed some information about her, wanted to know her diagnosis and whether her inpatient stay should be justified. And I was like, do you understand that she's asleep right now?
Her message went viral, but now she claims UnitedHealthcare is retaliating against her for it, and that it could bankrupt her.
Why do you think UnitedHealthcare is afraid of you?
I think it's all about money.
Dr. Potter is part of an alarming trend. She's just one of many people who claim UnitedHealthcare is trying to silence them for speaking out. I wanted to know, why is a $200 billion company afraid of one Texas surgeon? And who else has ended up in their crosshairs? And what is the company trying to hide from the public? So I went to her clinic in Texas to find out. This is Redbud Surgery Center. Dr. Potter opened it in 2024. It's a place where she can reconstruct living breast tissue for cancer patients who have had mastectomies. She does so by using the patient's own skin and fat.
I make it live by sewing the blood vessels of that tissue to blood vessels in the chest. So like hooking up a garden hose.
Yeah.
So essentially, to summarize what's going on, you have a clinician who was literally in the operating room. She received a call from likely a utilization reviewer from United Healthcare, who's typically a physician, sometimes nurses, but typically physicians make those calls, reviewing the case to determine whether or not her patient can be permitted to be staying overnight. So she's getting this call so that they can have a discussion, because apparently United doesn't agree, because if United agreed, then she wouldn't have received the call. It would have just been approved, case closed. So she's in the operating room. She steps out of the operating room to take this call, right? Because she wants to ensure that the care of her patient is not otherwise interrupted. But could you imagine being under anesthesia or in the operating room? Maybe the patient had just gotten into the operating room or had just finished the surgery and nothing acute was going on. I would just imagine that most clinicians won't leave the active part of the case. So that's an assumption on my part. Dr. Potter has not said this one way or the other to my knowledge, but nonetheless, she's still in the operating room and has to leave the operating room to take this call, this reviewer call, and is being told that she's not being approved for the services or for the overnight stay. So she has spoken out about it. She took to social media, which is what most people do when there is something that especially is an ongoing issue, which I would tell you a lot of providers feel that this is an ongoing issue in healthcare. And this may have been the straw for her. And the straw led her to go on social media. And she's been an influencer on social media for some time. So this was not new that she would be transparent with the public. And she shared what happened. Well, of course, this caused lots of backlash for United Healthcare. This, I believe the time frame was after the unfortunate loss of their CEO, led to, so already United was in the public scene and they were definitely receiving a lot of negative publicity. So after this happened, according to Dr. Potter, allegedly, even though I don't know if it's allegedly, if there is an active case, but we're going to say allegedly, United Healthcare has sought retaliation and has requested that she cease and desist her commentary regarding this particular case. Well, this has impacted her ability to receive contracts with other insurance companies, or this is her belief, because she has not been able to receive those contracts. It limits the availability of patients to be able to get her care at her facility. And this potential block can lead to her going into bankruptcy. That's a big problem, because it's not just it's not her personally going into bankruptcy. It's her it's her facility going into bankruptcy, which means this will impact patient care. And I don't know what the numbers are in her area, if she is one of few specialists, if she provides a type of, service in a way that patients have less access to. This matters. This turns into an access issue when it comes to patients. So this is a patient issue that we all should be paying attention to, not just some, random doctor and some random healthcare. It does have implications much greater than that. So moving along, apparently United Healthcare is not the only insurance company in the news. Now let's talk about Cigna. Cigna girl, what is going on? So Cigna's in the news because they have decided to reduce their reimbursement rates. So what Cigna is saying that they will follow the AMA's guidelines when it comes to billing codes for E&M. So evaluation management codes. So E&M codes are basically office codes that are used when a patient comes in to be seen. Your provider will bill an E&M code based on that office visit, which has different requirements for different levels. So the more in-depth the evaluation or the more complex the management, the higher the E&M code. If someone does a simple physical exam versus a more complete exam, such as an annual visit, the higher the E&M code. If patient has, diabetes, hypertension, heart disease, kidney disease, the management of that patient is going to be more complex, which is a higher E&M code than a patient who comes in for a simple UTI. Does that clarify? And so the American Medical Association has guidelines to help clinicians be able to meet these requirements. So Cigna is saying that they are going to follow this particular guidelines. And if they believe, and we don't know what that means, but if they believe that the clinician's documentation doesn't meet those particular guidelines, that they will pay less. Now, to let you guys know, the billing reimbursement rate for evaluation and management codes, which is these E&M codes, are already low. So for a lot of physicians, even at the current reimbursement rates, it's really hard to keep the lights on in the office. It's really hard to keep things going, which is why a lot of clinicians now are employed and not having their own practice. So this particular change is supposed to be starting as of October 1st, 2025, so this year. And there is pushback. And the pushback is that, for example, the California Medical Association was like, hold up, you gonna do what now? And you haven't been transparent as to, how exactly you're going to evaluate the documentation. So there may be some lawsuits in regards to this because this is a drastic change and they're not being completely transparent as to how the documentation will be evaluated. And so there may be a little bit of a pushback legally with the consideration with certain state laws that may implicate that this may be a violation of state laws, such as California. Now, if a clinician disagrees with the reimbursement rate, a clinician has the opportunity to submit a reconsideration or appeal. But here's the thing. Clinicians are already overwhelmed and burnt out with administrative work like this. So it's very unlikely that clinicians are going to go through the arduous process of submitting reconsiderations and appeals. So what's the likely outcome of this? If this really does go through, then unfortunately, patients who are under Cigna plan may have to change their plans moving forward, or may experience decrease in access because providers may not want to take Cigna anymore. And this is something you should pay attention to. So let us know, what do you think so far? We talked about a few things. Just to go back, do you agree with the decrease in funding for the Pediatric Brain Tumor Consortium? What do you think is the underlying cause for the cutbacks and layoffs at CHLA? What do you think about the dispute with Johns Hopkins and UnitedHealthcare? Are you taking sides? Do you think both are at fault? And what do you think patients should ultimately do? And what about the case with UnitedHealthcare versus Dr. Elizabeth Potter? Who do you think is in the wrong? Do you think she should have went on social media and shared her experience to raise public awareness? Or do you think United is in the right that it should have been a dispute that was taken care of privately? Let us know what you think. And what about Cigna? Do you think that Cigna is in the wrong? Or do you think that if these are guidelines that are established by AMA, then yes, they should be following those guidelines when it comes to reimbursements, and doctors should be made to be more compliant with those guidelines? What are your thoughts? And while you're thinking about that, let's talk about another reimbursement issue. So, do you guys know what CRNAs are? Well, CRNAs are certified registered nurse anesthetists. And chances are some of you who have had especially more minor surgeries may have been taken care of not by an anesthesiologist, but by a CRNA. And so let's talk about this. So CRNAs, here we go, United Healthcare once again in the news. Y'all, United, y'all are doing too much. We need to put y'all in timeout. So certain payers like United Healthcare, and United is not the only one, but they have announced that they're going to decrease the reimbursements for certified registered nurse anesthetists starting October. Dang, everything is happening in October this year, by 15% for services billed under a certain modifier. Now, this change aims to align CRNA reimbursement with that of other advanced practice providers and is already in effect for some payers like Medical Mutual, right? Here's the problem. The American Association of Nursing Anesthesiology has condemned these reductions, arguing that they are discriminatory and can negatively impact patient access care and increase healthcare costs. How you may ask? Well, let's get into it a little bit more. What you should know is that these changes will not impact certain states. For example, Arkansas, California, Colorado, Hawaii, Massachusetts, New Hampshire, and Wyoming. Now, critics argue that these reimbursement cuts reduce the ability for hospitals, particularly those with tight margins, to cover operating costs, potentially leading to service reductions and impacting patient access to care. So if hospitals aren't able to make their budgets, essentially what's going to happen is that they're going to reduce these services, or in some extreme cases may even close, especially like ambulatory centers may not be able to survive these cuts. So the other issue is that the cuts may actually decrease the amount of interest in becoming CRNAs. An anesthesiology assistant, which is threatening the role of CRNAs. So I will say that I was pretty shocked because I haven't paid attention to what their income and reimbursements are like. So when I saw this post, I was like, I have never been paid, even as a clinician, nothing close to what they are getting paid, to what this young lady is getting paid. And even though, there are certain things that may differentiate or cause differentiation when it comes to pay scales. But even when I was chief, I was nowhere near this income. Now, granted, my situation was a little sketchy because I did find out, even as chief, that I wasn't allowed to look at people's income, which was interesting. And I later found out that people who had just graduated and who I was supervising were paid more than I was paid. That's a whole other conversation. But that just speaks to how Black women are, once again, on the lower end of this pay scale. And even when we're in higher job titles or positions, we're still we still endure a much lower pay scale. So add to that being a Black woman and being in community health, my pay is very different from someone who is in private practice and who is not a Black woman. When you internet search physician income, keep in mind that Black women are still under 3% of all physicians and are more likely to experience discriminatory practice when it comes to our payments. So that being said, I can see why this would give some pushback in terms of the amount that they are paid. But the flip side of that argument is the fact that anesthesia, like OB actually, is one of the very highly litigious areas of medicine. And so they tend to have a higher malpractice insurance. And so it's said that the cost of being in that field is higher. And that is what is used to justify the higher income that they are paid. Again, these are hospital-based practices. They are oftentimes either hospital, ambulatory, surgical practices. It's very rare to be out of the hospital as an anesthesiologist. Even for those who do pain medicine specialties or subspecialties, they oftentimes have some type of hybrid practice. And so that being said, because of what they do, it has been justified for them to have a higher pay scale. So the critics of this move to reduce the reimbursements of CRNA, which has actually filled the gap of anesthesiologists, who is said to be also mass exiting out of the field because of pay reductions that they are experiencing without a comparable increase in recruitment into anesthesiology. And so the concern is that we're facing a shortage. And by doing these reduction, 15% is huge in someone's pay, right? Or in someone's reimbursement. So the thought is that this is going to disincentivize people going into becoming CRNAs. And they provide a high quality, cost-effective anesthesia care and are able to do pretty much what anesthesiologists do, just not on the most complicated cases, of course, but they do fill in the gap when it comes to access. There is the argument that this is discriminatory, that it's an undervaluing of what they do. And perhaps that is the truth because, like I said, they provide access to patients and make surgeries go much quicker. If there continues to be a mass exodus of anesthesiologists, of CRNAs, then that's going to impact the timing of surgeries. And so even if you have a specialty that's well staffed, they still can't do surgery without this particular specialty. And so you end up with longer waits to have your surgery done. And if you have been someone who's been waiting for surgery, you understand what that wait is like, especially if it's considered to be elective surgery. And while we're on the topic of hospitals, let's get into a little bit of a messy situation. Now, for some of you who've been following us for quite a bit, do you guys remember when we talked about private equity firms and the purchasing of hospitals and practices by private equity firms? And we talked about one particular private equity firm that was in the news for a maternal mortality case in Boston. Do y'all remember that? If not, let me refresh your memory. CBS did their own investigation and they found for this particular Steward company a trail of unpaid bills in multiple hospitals, including basic things like tubing for respiratory masks. They had just an ridiculous amount of outstanding balances, while at the same time, to your point, they were making these investments to suck out the equity, and then making these hospitals and other types of healthcare practices, it's not just hospitals, vulnerable and making them unsafe. They sold an equivalent of $1 billion worth of real estate of the hospital. And they had been selling out the real estate for the hospital systems since 2016. By 2021, their owners paid themselves millions in dividends.
We found evidence of lavish spending, including this $7 million Texas horse ranch Dr. De La Torre purchased in 2022, 2 corporate jets, and this yacht valued at an estimated $40 million.
Are not healthcare firms. They're in for making money. And what they do is they leverage the hospitals and the things they buy with debt, but they don't settle their own company with debt. They settle the company that they bought with debt. So St. Mary's Hospital, they settled St. Mary's Hospital with debt. Then what they start doing is they start selling off
Okay,
pieces of the
y'all.
land. They bring down staffing. They do all of these things to cut costs and improve and get higher profits.
I mean, the shadiness of Steward Healthcare. You're back in the news again. Let me give y'all the tea on what's been going on with Steward Healthcare, but perhaps this is the final straw. Maybe, just maybe, they may have learned their lesson. So earlier this week, a Utah judge awarded a $951 million settlement to a family. Let me repeat that. The judge awarded a family nearly $1 billion because of the suffering or long-term disabilities of their daughter due to what's reportedly, I don't know if I need to say allegedly, but allegedly negligent care during a childbirth delivery. Now, the judgment is against Steward Healthcare, once again, which represents the largest medical malpractice award in Utah's history. And this perhaps could be a signal to all of medicine for such a large award. Nearly $1 billion, you guys. Judge Patrick Quorum found Steward Healthcare liable for botched delivery of Azalea McMichael, who was born on October 14, 2019. Don't y'all go look up this child. Leave this child alone. At the West Valley City facility. Now, the award was granted to the parents for the five-year-old daughter who has lifelong disabilities resulted from negligent care during her birth. So reportedly, I don't know the details of this case, so I'm reporting based on news outlets and what they reported. And so according to news outlets, the nurses assigned to the mom had just completed their training and administered a dangerously high dose of Pitocin for induction of labor, while the on-call physician was asleep in, chances are, the on-call room nearby. The child was not delivered until the next day, 24 hours later. This child was under stress in the womb and didn't have a C-section until the next day, which many are saying was way overdue. So when the baby was finally birthed, it was noted that she had severe swelling of her head and complications consistent with oxygen deprivation. So she was probably anoxic. They later had to airlift her to a primary children's hospital in Salt Lake City for intensive treatment. Now, just to give you guys some perspective, as mentioned, obstetric is probably one of the most litigious fields of medicine for the obvious reasons. And typically, most in general malpractice lawsuits will range anywhere from 1 million to 15 million. That's about the typical range. So to have a award of nearly $1 billion is historic and probably earth-shattering for the entire profession. Now, granted, many people do agree that this was a negligent case. So what you should know about Steward Healthcare is that they operated 5 hospitals in Utah from 2017 to 2023 before selling to HCA Healthcare. These hospitals included Davis Hospital and Medical Center, Jordan Valley Medical Center, Jordan Valley Medical Center West Valley Campus, Mountain Point Medical Center, Salt Lake Regional Medical Center. The sale was part of a larger effort by Steward Healthcare to sell off its assets, including hospitals and physician groups, due to financial difficulties. Okay, Steward. So apparently HCA officially purchased the 5 Utah hospitals in 2021, and Steward Healthcare later filed for bankruptcy. Now, as I mentioned, go look up that case that happened in Boston. That was a situation. Okay. So unfortunately, there's even more things going on with healthcare. Man, I guess we can't get away from this AI. Now, AI is going after senior care. Okay, let's get into it. So it was announced that Medicare will be expanding prior authorization to include 17 specific procedures under traditional Medicare in 6 pilot states. That's Arizona, New Jersey, Ohio, Oklahoma, Texas, Washington. Some of y'all voted for this. Beginning January 1st, 2026, under the Wasteful and Inappropriate Service Reduction Model. I'll explain that model in a little bit. The new list includes services like certain spinal fusions, nerve stimulation devices, incontinence control devices, and certain skin substitutes. This program apparently aims to reduce what? Fraud, waste, and abuse. We've heard this over and over, but does it? Let's talk about it. What's interesting is that they have targeted to include additional procedures, and the AI companies that use an AI model, the AI will do the initial assessment as to whether or not these surgeries are warranted and should be approved for payment. Right. So how is the AI being used and how is it being programmed? That's a whole other conversation. But needless to say, we're at this point now. And so the AI model is going to determine whether certain procedures, as mentioned, like the spinal fusion, nerve stimulation that's used for things like incontinence issues, pain management like epidural steroid injections. So for some of you who have lower back pain, you're familiar with the epidural steroid injections, right? Other procedures like sacral nerve stimulation is included in this group, incontinence control procedures, percutaneous vertebral augmentation or vertebral compression fractures, arthroscopic lavage of the knee, for example, debridement of osteoarthritic knees, hypoglossal nerve stimulation for patients with obstructive sleep apnea, and the diagnosis and treatments of impotence. So for those with OSA, which is obstructive sleep apnea, who didn't want to use the machine or couldn't use the machine and decided to do the nerve stimulation option, now that's going to be challenged. And the question is, what criteria are they using to determine appropriate level? I will tell you, this is not new. These models have existed, just not with the use of AI. It has been physicians doing utilization review. I've been in the field, so I can tell you personally that this is not new. Okay. What is new is the use of AI or companies with AI to do this particular work. And they are also going to look at certain types of wound care as well. So I mentioned that they're using the Wiser model. So the Wiser model, the point is to use artificial intelligence to flag services that are costly, potentially unnecessary, and of little benefit to patients. Okay. In general, that sounds like a good thing, right? We do want medicine to be appropriate and to be effective and to be cost effective. Not just therapeutically effective, but also cost effective. Because if something's not cost effective, then guess what? It's not going to be therapeutic because ain't nobody going to get the procedure done because they can't afford it. Nonetheless, the Wiser model is a pilot program currently set to run in those 6 states that I mentioned, starting from 2026 through to 2020, starting from 2026 through to 2031. Now, here's the thing. They are going to exclude emergency services, thank God, and hospital stays, thank God. Could you imagine waiting for AI when you're in acute pain for an appendectomy to determine whether or not, even though appies are not on the list, but just as a very broad example, to determine whether or not your surgery is warranted? That would be wild. But this particular Wiser model was launched by the Centers for Medicare and Medicaid Service, that's CMS for short. Some of you may be familiar with CMS, that funds participating technology companies based on their ability to reduce costs for original Medicare. The specific funding model is a pay-for-performance structure. This is where it gets a little gritty. This is where we start to raise our eyebrows, because what they're doing is that they will provide a percentage of savings generated by the company. So in short, the companies that are using these AI models will get paid based on their ability to deny these procedures. The more cost savings that they're able to come up with, the more they get paid. So companies contracted with CMS receive payment calculated as a percentage of the spending reductions they achieve. These savings are derived from preventing payments for services deemed medically unnecessary or non-covered. Payments to participants are also adjusted based on their performance by three key categories. Process quality, measures such as volume of requests processed and the number of payment denials that are upheld. Provider beneficiary experience assesses the aspects like the timeliness and the clarity of decisions. And then they look also at clinical quality outcomes. It tracks metrics such as the use of alternative therapies and evidence of urgent clinical need. So the criticism is coming based on the fact that you're compensating companies based on cost savings that could create a financial incentive to deny as much as possible, potentially jeopardizing the access to necessary medical care for Medicare beneficiaries. Now, here's where it gets even a little bit stickier because who owns these AI companies? These extreme wealth individuals own these AI companies. Who is the Medicare beneficiary? Medicare beneficiaries are more likely the lower income seniors because the higher income wealthy seniors have private insurance. And so here is the transfer of wealth that people are eyeing and raising an eyebrow to because we realize what's really going on. You're taking money from seniors who are oftentimes on fixed income. If they're on Medicare, very likely they're on Social Security and have a fixed income. And you're transferring their funds to AI companies by denying them services based on an AI algorithm. What do you think about that? Don't forget to put your comments below because I really want to know what you guys think about that. Okay? Now let's get into another group that we're very concerned about when it comes to access of healthcare. Let's talk about our rural populations. Now, here is one of the things that I think has been very concerning. And it's been very concerning that I think the rural community feels that no one cares about them. And the truth of the matter is, we want the rural community to win. We want those who are living in communities that are more at risk for health deserts to win. Even if you don't have a humanitarian perspective on this, which we should, because human beings are human beings. But let's say you don't get the humanitarian purpose behind wanting them to win, just even from a financial basis. The less likely those communities thrive when it comes to their healthcare, the more costly their healthcare is. And traditionally, it has been other communities, metropolis communities, densely metropolis communities, especially in blue states, that have funded the bill to take care of those in the rural communities. So if the rural communities are allowed to thrive more and better, the less they will be a financial cost to other communities that are flipping the bill. So from a humanitarian perspective, and even from a financial perspective, it is in all our best interests that the rural communities thrive and win when it comes to their healthcare. But let me break it down a little bit more as to why we're now concerned about rural America and the big, beautiful bill. So it's been said that the big, beautiful bill is a win for rural communities, but is it? Let me explain what's really going on. So the big, beautiful bill, also known as the Rural Health Transformation Program, the bill allocates $50 billion over 5 years between 2026 to 2030 to rural hospitals. And that, again, $50 billion over 5 years, that means $10 billion per year. States will receive the funding based on factors like population size, rural health care needs, and hospital closures. States must submit detailed rural health transformation plans to CMS, which is the Centers of Medicare and Medicaid Services, by the end of 2025. That's specifically December 31st, 2025. This particular funding is intended to mitigate the impact of the $1 trillion in healthcare cuts over the next decade included in the bill. So let me tell y'all, when you talk about a sleight of the hand, this may be a perfect example of the sleight of the hand. So the Rural Health Transformation Program will not pay directly to rural hospitals. This is where it gets sticky, y'all, as past congressional direct relief funds have done. So in the past, congressional relief funds have went directly to the rural hospital, but not according to the big beautiful bill. It's a little bit different. There's an indirect route, and the question is, how do we ensure that the hospitals actually get the funding that they have been allocated? Instead, based on this new bill, the law now will fund the states, and the states will need CMS administrator, which is now Dr. Oz, to approve for how to spend the funds. So Dr. Oz now, Dr. Mehmet Oz, will now use broad discretion as to how states get to spend their funding. There's no specific requirement for states to directly fund the rural hospitals or for CMS to approve only expenditures to rural hospitals. Y'all. Let's go down this rabbit hole even more. So the administrator also has the discretion to approve the use of funds for non-rural activities. Regardless of what is funded, rural program allotments end in 5 years, while Medicare cuts are permanent. Let me say that one more time. Are y'all listening? The funding for these rural hospitals or the rural program, because it doesn't directly go to the hospitals, will end in 5 years, while the Medicaid cuts that have just been approved through the bill are permanent. So don't let them pull the wool over your eyes, y'all. Make sure you pay attention to what's really going on, because it sounds like they try to get the support of rural communities by sliding the hand. Okay, so Congress should have chosen to directly fund the hospitals as they have in the past, but instead this new law creates a state program instead. It's not really a hospital program, and the CMS administrator has the discretion to determine how the funds are allocated based on individual states. A massive $10 billion funding ends in 2030. And that's really when the Medicaid cuts are going to hit those communities. So basically, as the Medicaid cuts are hitting the rural communities, is exactly when the funding in this bill is starting to end. You see what they did? You see what they did? States now can use up to 10% of the allocated amount for administrative costs and expenses. I thought we were concerned about fraud, waste, and abuse. But a 10% can go to administrative costs and not to the direct care of patients in these rural communities. You see why we want rural communities to win. We want y'all to win. This ain't it. And they can receive an additional $200 million to administer the funds, making the total available overhead for the program $5.2 billion. Listen, y'all, $10 billion allotted each year for 5 years, just as the Medicaid cuts hit. At the same time, they have allowed for administrative costs to be up to 5.2 of those $1 billion. So $5.2 billion is now being allocated for administrative costs. Doesn't really sound like we're preventing fraud, waste, and abuse, but maybe have made a interesting funneling of fraud, waste, and abuse. Y'all, It's really sad when you hear these details because, like when people purchase things, they don't read the fine print. Most people haven't listened to the fine prints of these laws and instead are listening to sound bites. And I would recommend whenever new laws come out, take the time to go to those websites and read it for yourself and do the math for yourself because I'm gonna tell you when it comes to the big beautiful bill and these rural communities, the math ain't mathing at all. Here's the thing, this is why it's even more devastating because these communities have already been having financial struggles. And it was estimated that hundreds of hospitals would likely close at the end of this year as a result of funding challenges and financial difficulties. This may actually amplify that. In fact, there are economists that have estimated that this could double or triple the closures of hospitals and reduction of services. The Families USA found that independent rural hospitals could lose an average of $630,000 in total patient revenue in 2026, which could account for over 56% of their average income. Hospitals are often major employers also in these communities, and that's important to know because the closure of a hospital can impact significantly the economics of the entire community. Hospitals may be forced to eliminate essential services like obstetrics. Women's health are always one of the first areas to go because it's not a lucrative area for most hospitals. And so the vulnerable specialties include obstetrics, chemotherapy, and mental health services. Doesn't that make your heart drop? The loss of revenue and potential closures could force rural residents to travel hours for basic or even emergent care. Now, when you're having a heart attack, the time matters. How quickly you can get to the nearest hospital is literally the difference between life and death. And so the closure of facilities and the closure of hospitals can actually lead to an increase in the mortality rate. Don't think of it as just an isolation in terms of closures. We're talking about screening programs, we're talking about cancer treatments, we're talking about life-saving medical interventions when someone is having acute medical issues like a heart attack, like a stroke, or even just a simple appendicitis with delay can lead to rupture and morbidities and mortalities when it comes to the patient population. So an estimated 700 rural hospitals are at risk for closing due to financial instability, with some sources citing over 190 hospitals in Medicaid expansion states at imminent risk following April 2025. So they were already at risk for closure before the Big Beautiful Bill and all of the Medicaid cuts. A significant portion of the rural population is dependent on Medicaid. It is one of the most insured populations under Medicaid, and that's what people don't realize. And so when we talk about the Medicaid cuts, rural communities are the most vulnerable, and in addition to underserved urban communities, are the most vulnerable when it comes to these cuts. Other analysis suggests that over 338 hospitals in non-Medicaid expansion states are at particular risk. So here's the thing. Just because you're not under Medicaid doesn't mean you're not impacted. Because even if you're not a patient enrolled in Medicaid, you may be at a hospital that is dependent on the reimbursements from Medicaid patients. And so the loss of that funding can also impact your healthcare. These hospitals are at risk to have insufficient insurance reimbursements, depleted financial reserves, and potential healthcare cuts. This is a big issue. So this, amongst the humanitarian reasons, is why it's essential for rural communities to thrive. So definitely having access to healthcare is a public health issue. We can all agree on that. But there's other public health issues that warrant our attention just as much. So unfortunately, we are coming through a week with yet again another mass shooting. So I'm going to focus on a specific part of the discussion that needs to be addressed. It has to do with a comment that RFK Jr. made.
I certainly consider mass shootings a health crisis, and we are doing for the first time real studies to find out what the etiology of that is. And we're looking for the first time at psychiatric drugs. You know, these kind of mass shooting, people have had guns in this country forever.
So RFK Jr. in his media run on several interviews have implied that he is concerned about the impact of SSRIs, which is a category of antidepressants, probably the most common category of antidepressants used in the US, and its potential link to self-unaliving, and plans to study the link between mass shootings and the use of SSRIs. Now, there's so much I could say about that, but I'm going to focus my comments on what the science actually says. So the National Institute of Mental Health estimates that approximately 10% of adults in the US take some type of antidepressants, the most common of which are SSRIs, which are selective serotonin reuptake inhibitors. They account for up to 70% of antidepressant prescriptions in the United States, and were introduced on the market in the 1980s. Now, gun violence, not just mass shootings, because he has said that he thinks mass shootings are a public health issue, which is a gross understatement, because it has been shown and proven for many years that not just mass shootings, but gun violence as a whole is a major cause of premature death and injury in the United States, especially for young people, as unfortunately evidented by this heinous crime in Minneapolis. Now, it's important to address the issue head on, and this is why someone who understands science is critical in this position, because to understate the impact of gun violence while people are living in communities where they're impacted by gun violence almost on a daily basis is a gross negligent statement to make, to only focus on mass shootings, because there are communities, especially communities of color, that are severely impacted by gun violence, not because communities of color are more violent communities, but because gun violence is linked to poverty. But we'll talk about that in another. Depression is not unique to the United States, and neither is the use of SSRIs. SSRIs are not just used in the United States, but around the entire world. Yet you do not see other developed countries having the same issues that we do in the United States. What differentiates the United States and other countries is not the rate of mental health disorders. It is not the use of SSRIs. It is specifically gun laws. Gun violence is a leading cause of death for children and adolescents ages 0 to 19. I don't know if you guys saw the videos of a mom talking about she now gives her children bulletproof protected backpacks in an attempt to protect her children as they go to school. If that's not a signal of a problem, I don't know what else is. Nearly all of the United States have a higher firearm mortality rate than most other countries. Gun violence has been linked to trauma and violence. So the more traumatic experiences that are experienced by a community, the more likely the community will be impacted by gun violence. Substance abuse, poverty, lack of opportunity, and easy access to firearms. These are all proven linked causative factors when it comes to gun violence. So let's not minimize the impact of gun violence as a public health issue just to supplant the ideology that has been not proven, because that will result in us missing the opportunity to really impact and save the lives of our children. But even if you don't believe it that far, let me break it down a little bit more for you. In 2004, the FDA placed a black box warning, the agency's strongest caution on all antidepressants for children and adolescents. The warning was extended in 2007 to include adults up to age 24, noting an increased risk of unaliving thoughts and behavior during the initial stages of treatment. Now, again, having the thought, having a plan, and attempting are all different level of risk. And having thoughts does not equate to a plan or attempting. A key point of the analysis showed that the increase in having unalived thoughts and behavior was not associated or correlated with completed unaliving, and that no completed unaliving occurred in the trials. So while there is a concern that there is an increased risk for unaliving thoughts, there is no evidence that that correlates, or has there ever been found a correlation or a link with people unaliving in any of the trials or studies that have been done. But this is not the first time RFK Jr. has said something that has caused us to clutch our pearls, scientifically speaking. And perhaps one of the communities we could have learned the most from was the Samoans. And you may ask, what happened with the Samoans and RFK Jr.? This is something I definitely ask you to go look it up and make sure you're aware as to what happened. But the Samoans controversy when it comes to RFK Jr. occurred as a result of his visit to the area in 2019, in which he promoted anti-vaccine advocacy and did so in association with his organization, Children's Health Defense. Unfortunately, allegedly, he spread misinformation about vaccinations. And this came, unfortunately, after an incident had happened, an unfortunate incident had happened in the hospitals, where in 2018, nurses incorrectly mixed vaccines, which led to the deaths of 2 infants. And so the community was already on edge and had some trust issues when it came to vaccines because of the administrative error or clinical error that occurred with the improper mixing of vaccines by the nurses. Well, the Samoan government had temporarily suspended its vaccine program in response to the error and the death of the infants. Now, fast forward to 2019, the year later, RFK Jr. is now visiting, perhaps intentionally, allegedly, the community. He visits the community and uses the opportunity, allegedly, to promote anti-vaccine ideology. As a result, there was a decrease in the vaccination rate of the population, and there was a measles outbreak that began in September 2019. The long story short, the end result was 83 people died, and mostly children. The vaccine rate among eligible 1-year-olds had dropped significantly to 33%. And so people have allegedly associated his anti-vaccine rhetoric during a time in which the population was vulnerable because of the incident that happened the year before to be responsible, allegedly, for the unaliving of 83 people as a result of a measles outbreak. Unaliving of kids as a result of a measles outbreak? Sounds familiar? It should. Is there a correlation with the timing of RFK Jr. becoming the head of HHS? Allegedly. Allegedly. There may be a correlation. But this is not the first time he said things that, again, have caused us to clutch our pearls scientifically. RFK Jr., in recent interviews, when asked about the dismantling of the CDC, has tried to justify it by saying that the CDC has promoted even achievements on its website in regards to abortions and vaccinations and the use of fluoride. Now, I definitely ask you to look up his views on the use of fluoride. He does want to eliminate fluoride from our drinking water. And as mentioned, he historically has had anti-vaccine beliefs. Now, when it comes to his claim that the CDC promotes that one of its achievements on its website is ABs? Let's look deeper.
The word abortion's not in there at all. Okay, so what HHS said to us when we reached out and said, hey, abortion isn't mentioned in the top 10 list of great achievements in health. They said, okay, family planning is, and then they said, they linked to a page that had to do specifically with family planning, going deeper on that one bullet point, and which mentions abortion. So, okay, let's go there and see what they're talking about. So this is, again, CDC, and it's about family planning. So here's the question. Does the mention of abortion in this mean that they're talking about abortion as an achievement, or is abortion just used in some other context? So let's do a search for the word. Okay, abortion appears 5 times in here. So this one is just a history of the modern birth control movement. Margaret Sanger, concerned about the adverse health effects of frequent childbirth, miscarriages, and abortion. Okay, so that's obviously not saying abortion is some great achievement in health. This one is about physicians are the primary providers of ways to have family planning, meaning contraception or surgical sterilization, etc. These services prevent an estimated 1.3 million unintended pregnancies. So the goal in family planning is to prevent unintended pregnancies. And how do they get to that number, 1.3? Well, here's 534,000 unintended births, 632,000 abortions. So again, they're not saying abortion's like some great achievement. They're citing it as an example of unwanted pregnancies. All right, so that doesn't count either. There's another mention here. United States, unintended pregnancy remains a problem. 49% pregnancies are unintended, 54% of these end in abortion. Here they're actually saying abortion is evidence of a problem of unwanted pregnancies. And it says the U.S. ranks 4th highest in total fertility rate and had the 2nd highest abortion rate. Again, it's an indication of the fact that there are too many unintended pregnancies, which is why they think contraception is such a great thing. And then, so that's 3, that's 4. And then the 5th mention is just in a history of milestones in family planning. It mentions Roe v. Wade legalizing abortion in 1973. Obviously, that has been changed in the Dobbs decision. So what are we to make of all this? We're to make of it that Robert F. Kennedy Jr., when he said that the CDC said abortion was one of the 10 great achievements in healthcare, that CDC had said that was not true. And then when we challenged them on that, what are you talking about? They tried to come up with a way to retroactively make it true by noting that the word abortion appeared on the family planning page, although it did not appear in the context of an achievement. It appeared in the context of this is evidence of unintended pregnancies or unwanted pregnancies, which is why contraception is good. And this really illustrates something that the scientists at the CDC have been saying, which is Robert F. Kennedy says things that aren't true, and he bases them on a foundation of lies, and this is having an impact on American health. So that's what I spent this morning doing.
So as you see, it's not on the website. And I highly recommend when you hear claims like this, do your homework, check into it yourself, and make sure you're just not believing what people are saying, especially when they have a history of allegedly not being the most honest and truthful individuals and have been caught in several untruths, allegedly. Now, and yet, that alone is not the only interesting claims that he has made when it comes to vaccines, especially those of us who are Black should very much pay very close attention, because if you remember, during his confirmation hearings, he said something that sent off alarms like a 5-alarm fire. In his hearings, he explained his ideology that Black people need less vaccines because our immune systems are stronger. I talked about this not that long ago. That belief dates as far back as the 1800s, and it's the belief that Black people have stronger immune systems. So let's talk about that. It was mentioned in the hearing this past week that Black people have stronger immune systems. And this coming right after we went through the pandemic, where disproportionately Black people died. But yet, this false belief still haunts us. So again, like your mama would say, take everything he says, allegedly, with a grain of salt. You know what I mean? So there's been other things happening when it comes to the FDA and the CDC that have also been concerning, and some things have been sliding under the radar. So one of the things that has slid on the radar is the fact that our food safety programs have been scaled back. Yes, the CDC has scaled back the food safety program. The Foodborne Disease Active Surveillance Network, called FoodNet, a collaboration between the federal health agencies and 10 state health programs or departments, was previously required to track foodborne illnesses correlated with eight pathogens, but recently has decided to scale back to only 2 pathogens and monitoring and tracking only for Salmonella and Shiga toxin producing E. coli, according to NBC News. Other systems apparently in the CDC will continue to monitor for others, is what they claim. FoodNet is a national food safety program, and it has stated that they're scaling back these tracking programs and its operations due to prioritization and funding cuts. Now, the bacteria that are no longer going to be a part of their tracking program include Listeria, Campylobacter, Shigella, Cyclospora, Vibrio, and Yersinia. Now, Listeria for my pregnant moms, that should catch your attention because we've shared on this program also the risk of infection with Listeria, especially during pregnancy. Now, all of these pathogens are very serious and have very serious outcomes. But we should keep in mind that these are not the only cutbacks of the CDC. There have been other cutbacks that we definitely need to pay attention to, especially when it comes to COVID-19.
Holy cow, folks, I told you this was going to happen. The FDA has approved the COVID vaccine for only people who are 65 and older, or those who have what are considered increased risk for developing severe COVID. In front of you is the list from a New England Journal of Medicine article that was published by the FDA commissioner recently, and you can take a look at it, pause to read. I think the easiest thing on this list, if people are wanting to get a vaccine, is to say you're physically inactive according to this list, and that it's important to talk with your doctor about this. But keep in mind that this is not fully approved yet because the Advisory Committee on Immunization Practices needs to meet in order to make formal recommendations, and then the CDC Director signs off on it. But keep in mind that the ACIP has been compromised by RFK Jr. because he fired the entire panel and replaced it with half the number of people, mostly consisting of anti-vaxxers. So holy cow, folks, it looks like some health insurance companies are likely going to still cover the COVID vaccine despite the turmoil that's happening at the FDA and CDC. This is according to a report from Reuters that stated that Aetna, which is a large health insurance company in the United States, is still going to plan on providing free COVID-19 vaccines for those that are insured. It's unclear what other health insurance companies are going to do, but starting next year, all bets are likely off, and it's going to be based on the recommendations that come from the CDC. Now, FDA.
So the biggest story recently is the complete debacle at the CDC with the firing of the director of the CDC, Dr. Susan Manares, who has recently been appointed the director of the CDC, which is the Centers for Disease Control and Prevention for all of our international viewers. But she was forced out of the position. And allegedly, the reason why she was forced out of the position is because she refused to sign off on policies that she thought were not proven by scientific vigor. And she wanted to be able to analyze the science before signing off on policies. Well, this caused folks to ruffle their feathers, and they wanted her out of the position, and she refused to leave the position, but then was officially fired by the president. And here is what they had to say about her firing.
Secretary asked her to resign. She said she would, and then she said she wouldn't. So the president fired her, which he has every right to do. It was President Trump who was overwhelmingly reelected on November 5th. This woman has never received a vote in her life, and the president has the authority to fire those who are not aligned with his mission.
So some people may be asked, what exactly is the mission of the president? Do we know? What's the mission of the HHS? Because there are a few things that have our eyebrows raising, okay? But not only did Dr. Monares left, but so did very key personnel in the CDC, which is what has caused people to be so concerned because these individuals have long careers of being not just a part of the CDC, but part of the scientific world that has kept us protected from potential pathogens for many years, leaving many people to wonder what would happen if we were to encounter another pandemic.
My name is Dimitri Daskalakis. I'm an infectious disease doctor, and I was the director of the National Center for Immunization and Respiratory Diseases.
I'm Dan Jernigan. I was, until recently, the director of the National Center for Emerging and Zoonotic Infectious Diseases at CDC.
I'm Dr. Howery. I was the chief medical officer who turned in a resignation yesterday.
I tendered my resignation because I could not be a part of the weaponization of public health and CDC.
We really think that the use of the scientific information as evidence to help the decision-making with vaccines is critical. And if that is not the approach that is being taken, then Americans are not getting what they need from us.
I'm a scientist. I think it's okay to question, but you shouldn't know what your recommendation is going to be before you have the data. We should always be questioning, but you shouldn't have a preconceived idea before you have the data.
I fear that without scientific leadership, and what I mean by that is the director of CDC, there will be decisions made around vaccines that are based on pre-decided ideas rather than based on presentation of high quality science and discussion.
I think there is a scientific process that we need to be following, and there is the ethical responsibility of how we handle.
It's gotten to the point, you guys, that Senator Bernie Sanders, ranking HOPE committee member, so the oversight committee when it comes to our health and public health, has called for a bipartisan congressional investigation on what happened.
Voice and the voice of my colleagues that also resigned with me will be more powerful on the outside.
What does reaching that tipping point, as you put it, mean to you? You saw Dr. Monares' lawyers reference the unscientific and reckless directives. What does that mean to you?
Yeah, so we have an immunization committee meeting coming up in a few weeks, and many of us, myself included, were concerned about some of the recommendations might walk back vaccines in our country. To me, that's one of the tipping points. I think another tipping point is just the loss of Dr. Monares. We hadn't had a CDC director for several months. When she came on board, she brought scientific rigor and some new ideas around public comment and how to really make sure data drove the decisions. When she had done some of these changes, she was brought to the secretary's office for discussion. And at that point, I became concerned that she wouldn't be able to implement changes that were needed at CDC. And without that leadership, it would just leave us vulnerable again. And I thought that that was the point to say enough is enough and to really raise that bat signal that public health and CDC is in trouble.
You've also said previously that her firing makes it easier for Secretary Kennedy's appointees to change vaccine recommendations. You just mentioned fearing a walk back in some of those vaccine policies. What does that mean specifically? What could we see ahead?
So, if we don't have a CDC director, and if there's not an acting CDC director, then the secretary would sign recommendations like he did for the last ACIP or vaccine committee meeting. So things like the COVID vaccine or hepatitis B vaccine, they could choose to change ages on it or the populations that have access to it. I'm just concerned about changing vaccine access in our country and that we need to focus more on the safety and effectiveness of vaccines, shared decision-making around vaccines, and not talking about misinformation around vaccines.
Nonetheless, since the leaving of Dr. Monares, she has been replaced by another individual, Jim O'Neill, someone who is raising many eyebrows. Who is Jim O'Neill? Well, let's talk a little bit about him so you know. Well, the first thing you probably realize is that he doesn't have doctor in front of his name. Jim O'Neill is a longtime biotech investor, close to the billionaire Peter Thiel. Many of you have been monitoring probably the moves of Peter Thiel because he seems to be coming up in many interesting circumstances. And he did a stint at the HHS with former President George W. Bush administration, where he was involved in the public speaking, and said little publicly about vaccines at that point and kept a very low profile, becoming eventually Kennedy's second in command. During his confirmation hearing in May, Mr. O'Neill told Senator Bill Cassidy, who is a clinician by trade, a Louisiana Republican, that he's very strongly pro-vaccine and supported the CDC's vaccine schedule. Now, O'Neill previously helped run one of Thiel's investment funds and later managed several of his other projects. Those included a nonprofit working to develop man-made islands that would float outside U.S. territory, allowing them to experiment with new forms of government. Now, I definitely recommend you look up Peter Thiel and his ideology when it comes to government. That's going to be very critical for you to fully understand the circumstances and the information that I'm sharing so that you can connect the dots. Mr. O'Neill has no training in medicine or in healthcare and holds a bachelor and master's degree in humanities. Now, humanities is not healthcare, and it's certainly not medicine, just so you know. Just because it says humanities, it doesn't mean it has to do with healthcare. It doesn't. Although O'Neill did use social media to criticize the FDA efforts to stop the prescribing of unproven treatments for COVID-19, including the anti-parasite drug ivermectin. So he was a supporter of the use of ivermectin and a supporter of the use of hydroxychloroquine when it comes to combating COVID-19. Now, that for many of us should raise eyebrows. He also has longstanding ties to the libertarian wing of the Republican Party, including with Peter Thiel. Now, again, look up the ideologies of the libertarian wing of the Republican Party. One of Trump's leading supporters from Silicon Valley is Peter Thiel. And like Thiel, O'Neill has expressed disdain for many parts of the federal bureaucracy, saying it hinders advances in medicine, technology, and other areas. So they believe strongly in the dismantling of the federal government in some, just in case you haven't picked it up yet. In fact, he proposed with doing away with the FDA's 60-year mandate of assuring new drugs are both safe and effective in treating diseases. In a 2014 speech, O'Neill suggested drug efficacy could be established after the drugs hit the market. Okay, now here's the part that warrants your very close attention. So recently, as I shared, the CDC came up with new guidelines as to who is eligible for the COVID-19 vaccine. And what they did is they separated the most advanced age individuals will be eligible for the vaccine. But for everyone who's younger, you have to have a certain medical condition or one of the exemptions in order to qualify to get the vaccine. So what does that mean for most individuals in the U.S.? For those who are considered to be a healthier population, will no longer be eligible for the vaccine. And moving forward, whatever is not approved by the CDC and the ACIP will likely not be covered by insurance companies. And the question is, how much will it cost to get the COVID-19 vaccine if people were to have to pay out of pocket? And with that, it would lead to the COVID-19 vaccine being an elite option because, of course, those who are underserved and impoverished wouldn't be able to afford it, but those who are wealthier would be able to afford the vaccine. I will definitely tell you as a clinician, because we are constantly exposed to COVID-19, constantly, and have lost such a huge part of our labor force in medicine, which is something that's not being talked about, as a result of direct unalivings, as a result of the virus, and those who left the field because of the traumatic experiences. So for us to then continue to work a job where we're continuously exposed, but isn't included in the highest risk group to be vaccinated is absolutely concerning. and I would say a gross negligent oversight of the committee. But the committee has changed significantly. This is the committee before, and this is the committee now. So clearly the representation of certain communities may not necessarily be considered, such as pregnant women. Pregnant women have definitely been considered to be at risk for COVID-19. And not only does it impact the life of the mom and the life of the child while acutely infected, but there has been correlations and adverse outcomes to the pregnancies of women who have experienced the COVID-19 infection while pregnant. So there are long-term consequences of the infection. So it's not just about surviving, but it's about preventing some of these long-term outcomes that increase the overall morbidity and morbidity of individuals, meaning people now who have heart conditions who didn't have heart conditions before as a result of having the virus, and now have long-term alterations in their lifestyle because of it, and now also have a higher cost of medical care because they have to be monitored or treated. These are the parts of the conversation that's not being discussed. The key thing that is not being discussed, that is probably the greatest concern I have, is the fact that we're not assured that the CDC moving forward will be diligent about collecting data and diligent about how the data is analyzed. Without your most experienced scientists that are able to really interpret scientific data in a way that makes it applicable to the rest of the public, then we are at high risk for not even having the information needed to know what's going on. And we've already started to see this happen on a smaller scale in states that have more restricted laws when it comes to ABs. And the initial data showed an increased rate of mortalities amongst women as a result of these higher restrictions. And what did a lot of those states do? They dismantled their committees that were monitoring the data. And so there is now no data coming out of these states to really be able to say and demonstrate the negative impact of the policies. What you don't know will hurt you.
You're now on the record. You lied to Senator Cassidy. You have lied to the American people. You have lied to parents about vaccines for 20 years. And I also want to be clear that I will lay all responsibility for every death from a vaccine preventable illness at your feet.
You guys, so that is my recap for today. I hope it helps you to really understand a lot of what's going on. There's so much going on so quickly. I wanted to do a Beyonce world stop so I can explain in detail what you need to know to make good decisions for your family and to prepare. If there were to be a take-home message from all of this, I would say be your healthiest so that you don't need to rely on the medical system, right? So be at your best health. And then also try to get a lot of your services done this year. Try to get your annual visits, your annual exams, your preventive care, your medication, be well stocked in your meds by the end of the year, because next year is about to be a situation, and God help us. And I don't say that lightly. This is Dr. T, the hand behind the handle of Healthy Bump Club right here on YouTube and healthybump.club on Instagram. We thank you guys for watching. We thank you for joining us today. Let us know in the comments, what are your thoughts about all these things that are happening? Does any particular issue stand out to you personally because it affects you personally or your loved ones? We want to know. And how are you circumventing some of these changes? We want to know that too, because we can help each other, because we're all creative beings and are able to take in information and have creative ideas. So this platform is an opportunity to share those ideas so that we're able to help each other. And we hope to be that source and that safe space moving forward. We thank you guys for watching us today, and we hope to see you guys when the next episode. This is Dr. T, just a friendly reminder. Don't forget to comment, like, and share. And go ahead, why not? Click that subscribe button. Help us to get to the next 1,000 subscribers. We thank you guys for supporting.